Maybe just antsy. Yeah.
Okay. Let everybody filter in. Give everybody a couple of seconds to come in. I see the room filling up.
Mhm.
All right. All right, Daniel. I see that we're at the top of the hour now. Do we want to get started?
Sure. Ready to
All
go.
right. Good stuff. I'm going to share my screen, so just bear with me. Hello, everyone. Welcome to today's session. It's great to have you here, especially on National Hospice Palliative Care Week. I do recognize that there are still some people filtering into the room, so hopefully everybody pops in quite quickly and we'll go ahead and get started. So today's session is From Blueprint to Action, How We Can Advance Palliative Care Together in Canada. So this session is really designed to be a practical introduction to government relations and advocacy, specifically for those working in hospice palliative care. So, just before we move on, I just want to say that the goal here is to help you understand how advocacy actually works in Canada, where you guys fit into the system, and what small practical steps you can take. So, you don't need to be a prior advocacy expert to be here today. It's a general session for everyone. So, I would like to introduce and thank my co-presenter for being here today. So I'm going to turn it over to you, Daniel, to tell the audience a little bit about yourself.
Thanks, Cheryl. Hi, everyone. My name's Daniel Nowoselski. I am the Senior Advocacy Manager at the Canadian Cancer Society. My pronouns are he, him. I've been at CCS for 6.5 years and in this role for almost five. Before that, I spent 8 years working in provincial politics in Ontario and have mostly studied public administration. But for me, like many of you, I came to palliative care through the personal experience I had, helping to care for my dad, Barry, at end of life, at home during the peak of the pandemic. We had amazing support, but we had every privilege in the world, and still many days in that journey, it felt impossible. At the same time, CCS also happened to receive a donation from the Don and Shirley Green Family Foundation to scale up our advocacy in palliative care. We at CCS have a unique place in the system. Palliative care has been born out of cancer care, and in some cases is still guided by cancer agencies across the country. But we've always advocated for better palliative care everyone. I'm now also honored to chair the Palliative Care Coalition of Canada, because we know that in this will in turn benefit people with cancer. And we use our position, our relationships, and our profile to amplify what you and the people you care for need.
Great, thanks, Daniel. And I'm Cheryl Spencer. I'm the interim CEO of CHPCA. My pronouns are she, her. This is a role I've held since November, where prior to that, I was acting co-CEO role since March 2025. I've been with the association for the past 17 years in various roles, so I've had the opportunity to do a lot of different things at CHPCA. And I am currently serving as the secretary of the PCCC alongside Daniel. So, before getting into today's presentation, I would like to acknowledge that although we are gathering virtually, it's important to recognize the territories where we live and work. And recognizing the enduring presence of the First Nations, Métis, and Inuit people across this country. So, CHPCA acknowledges that the territories where we're headquartered are located on the unceded territory of the Algonquin Anishinaabe Nation, and Daniel's joining us from the traditional territories of many nations, including the Mississaugas of Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people covered by Treaty 13 with the Mississaugas of the Credit, whose presence reaches back to time immemorial. So we pay our respects to their elders, past, present, and recognize their ongoing connection to this land. So with that, I would like to start our presentation today. So as I already said, it's From Blueprint to Action, How We Can Advance Palliative Care in Canada Together. So just very briefly, these are the objectives we'll cover in today's session. So the focus of today's session is not just to talk about advocacy in theory, but to help each of you really understand the system and see how it connects to the work that you do and identify where in your programs and services you can actually take some action. So before we get into that, it's helpful to ground the presentation a little bit in who's leading and advancing hospice palliative care work at the national level. So the Palliative Care Coalition of Canada is made up of more than 30 national groups. Each of these organizations has their own mission, mandate, priorities, and do their own advocacy work. But at the same time, they're coming together around a shared, coordinated national voice for hospice palliative care. So this becomes the voice of the Palliative Care Coalition in Canada, or the PCCC, as you'll hear us refer to it throughout the presentation. So what this means in practice is that organizations like CCS and CHPCA, we continue to advance our own work while the coalition aligns around around the shared palliative care priorities, specifically at the federal level. So this multi-organizational alignment really helps to strengthen the overall palliative care message and helps that ensure that palliative care is really being represented in a consistent and a unified way across the country. So that consistency really matters because governments tend to respond more strongly to a coordinated voice on an issue. So when multiple organizations are aligned and reinforced around the same priorities, it helps to build the credibility and improve clarity of messages that also ultimately increases impact at the government level. So Daniel.
Yeah. So the Blueprint for Action for 2025 to 2030 is a national roadmap developed through the Palliative Care Coalition of Canada. It's essentially our strategic plan for what we want to accomplish. It highlights the shared recognition across the sector that while there has been progress made in palliative care, there are still significant gaps in access, awareness, and system capacity throughout the country. The purpose of the blueprint is to bring alignment across organizations, to identify the most important areas for action, and to provide a clear and coordinated direction for advocacy and system change. What makes this important is not owned by one organization. It represents a collective national vision for hospice palliative care in Canada. We worked with the members of the coalition and partners like the Canadian Partnership Against Cancer's Palliative and End of Life Care National Network and Health Canada to determine the nationwide priorities. And this work was sponsored through the donations we received at CCS to support the Don Green Palliative Care Advocacy team, which I lead. Our plan for 25 to 2030 is an update from 2020 to 2025. We felt that we needed to acknowledge and celebrate the work done so far, while also updating our path forward based on our new knowledge and ways of thinking about palliative care. For instance, we wanted our work to evolve to reflect the importance of integrating a palliative approach to care throughout our entire healthcare system beyond just specialist palliative care. And I feel that our recommendations reflect that. The document also reflects the value of interprofessional collaboration in the delivery of care, translating best practices into system change, and making sure equity is embedded into everything that we do. We also wanted to make sure we were aspirational in our vision, but practical in our ambition. Well, being able to communicate the importance of this work in palliative care. So we wanted to identify desirable outcomes of our work while identifying the steps we want to take to get there.
Perfect. So very briefly, I'll walk you through the 4 priorities of the current Blueprint for Actions, just so that you can see what they mean in practice. So the first priority area is an engaged and informed public. So this is really about ensuring that Canadians, understand what palliative care is, know how and when to access it, and feel more comfortable in having conversations about serious illness, dying, and grief. So, in practice, this really can include things like advanced care planning, public awareness campaigns, community education initiatives. And because we know that there's a really big lack of awareness, and that's still one of the really biggest barriers to getting access to good quality palliative care. So, the second priority area is around skilled and supported care providers. So this priority is focusing on the workforce mainly. So it's recognizing that many providers are delivering palliative care without formal training, that there's gaps in education and confidence and support in delivering palliative care across the country, and that burnout and system pressures are real challenges. So these areas are including a lot around training and education, interdisciplinary support, tools and resources to help providers deliver a palliative approach. The third area is knowledge to improve care. So this is about strengthening the evidence base. So in this, we really recognize that we need better data on access and outcomes and research to inform best practices, and we need tools to measure quality of care. So this also includes things like knowledge translation and making sure that what we know is actually what's used in practice. And the fourth and final area is equitable access to palliative care for all. So this is really at the heart of the blueprint. So this is recognizing that access to palliative care is not equal across Canada. So there's gaps that exist for rural and remote communities, people experiencing homelessness, Indigenous communities, non-cancer diagnosis, pediatric population, others as well. The list goes on for sure. So this priority is really about ensuring that everyone, regardless of who they are or where they live, has the same access to good quality hospice palliative care. So when we're talking about advocacy today, we're not talking about it in an abstract form. We're talking about how do we take these particular priorities and move them forward. So how do we do something like the blueprint, which is a shared vision that and actually translate it into policy decisions, funding programs, and make real changes in the system. And that's where advocacy and government relations come in. So before moving on, I just want to mention an important point. While we are using the blueprint priorities as examples today, the way advocacy works is very similar across all levels of government. So whether you're engaging sort of federally, provincially, or at the local level, the core mechanisms are really similar. So you're really working towards identifying an issue, defining your clear ask, building those relationships, and communicating your messages in a way that resonates with decision makers. So we'll get into what all that means as it goes forward in the presentation. So just recognizing that advocacy does happen at multiple levels. So the local level, which is often where we see the most day-to-day advocacy happening. So this might include as you're advocating for program funding or service delivery or operational support. So many people that are listening to the webinar today are really doing this type of advocacy work in their programs already. So the provincial level is often led by the provincial palliative care associations and other provincial associations focused on system level issues like funding models, standards, coordination across regions. And then there's the federal or national level. And this is where the Palliative Care Coalition, CCS, CHPCA, this is where we're typically focusing our work. So we're working on a broader policy, national frameworks, and funding envelopes for that. So the big takeaway in all of that is that priorities may differ depending on your region or your role, but the approach that we're going to talk to you about today is really consistent across anything that you're doing. So what we're talking about today is meant to translate directly in your day-to-day work. So while we are talking about the national that sits at or the blueprint that sits at a national level, its issues are really speaking to the core of what many of you are dealing with in your everyday work. So advocacy is really about creating a connection between those experiences and the decisions being made at the different levels of the system that can help make those changes happen. So when we're talking about palliative care, it's really easy to think of it as primarily as clinical work. But access to palliative care is not just determined by what's happening at the bedside. It's really shaped by the decisions that are being made at a policy level. So public policy influences things like whether palliative care is available in your community, whether it's integrated into primary care, funded in hospitals, hospices, home care, and whether it's accessible to different populations. So making this a little bit more concrete, policy decisions really are determining whether there's funding for hospice beds in your region, whether community-based palliative care teams exist and how those are structured, and whether patients can receive care at home versus being being admitted to a hospital, and also how early palliative care is introduced into the care journey. So you're going to see this playing out in your work as patients staying in hospitals longer than they should because there's no access to community supports, families struggling to access services outside of urban centers, limited resources for non-cancer diagnosis or pediatric care or other populations such as that. So staffing challenges that are that affect the type and quality of care that you can provide. So none of these are just strictly clinical issues. They're really the result of funding decisions, policy decisions, system design choices. So when we're talking about advocacy, we're really talking about how do we take what you're seeing every day in your work and make sure that it is informing these decisions at the system level. So, because those decisions ultimately shape the care that you're able to provide and the options available to patients and families and the overall experience at end of life, advocacy becomes this really big bridge between what's happening in practice and how the system evolves over time. So now that we've talked a bit about why policy matters, I want to step back just a little bit and ground us in what we actually mean by government relations and advocacy. So these terms can feel a little bit abstract and oftentimes even intimidating. So the goal here is really to sort of help suss that out and make it feel a bit practical and understandable. So, what is government relations? So, government relations is really about influencing and shaping public policy to achieve a specific objective. So, it's about something more than that as well. It's about building a relationship and creating two-way dialogue with your government. It's not just about asking for the changes that you want to see happen. Well, advocacy is the act of supporting a cause or a proposal. So, in our context, we're using government relations approaches to advocate for better access to hospice palliative care. So, whether that's funding, policy programs. So, you're often going to hear those terms a little bit interchangeably, and in practice they do overlap. But there are some important distinctions between them. So the other key term that you may hear is lobbying. So lobbying is a formal regulated activity that involves direct communication with public office holders to influence decisions. So there are rules around lobbying, and not everyone needs to or should be lobbying. So advocacy, on the other hand, is much broader, and it includes things like raising awareness, sharing experiences, engaging in your community, or contributing to the conversations that are shaping policy over time. So, one of the most important things to understand is that effective advocacy is not just about asking for something, it's about providing information and sharing expertise and helping decision makers understand the issues that are at hand. So for this group, your main takeaway is that you don't need to be a lobbyist to be involved in advocacy. In fact, some of the most important advocacy work is happening outside of formal lobbying. It's really happening through the relationships, through storytelling, through consistently showing up and having the conversations with everybody, really. So when we talk about advocacy, it's really helpful to think about who we're actually trying to reach here. So you're going to hear the term decision makers throughout our presentation today. So it's important to understand that that's not just one group of people, it's an entire system. So decision makers are the people and organizations that influence policy, shape funding decisions, and really design and implement the programs. So one of the most important things to really understand is the different people play different roles in that system. So for example, elected officials like MPs and MPPs are responsible for setting direction and making final decisions. Public servants, on the other hand, are the ones who are designing policy, developing programs, and they figure out how to get things actually implemented. So often, these are the ones that you're going to interact with the most. This is important because effective advocacy is not just about speaking to one person. It's about understanding who does what and engaging accordingly to what those roles are. There's also a broader system beyond the government itself. So this is looking at agencies, health authorities, other organizations that are influencing how those decisions get carried out. And all of this, to note, is existing at multiple levels of government. So municipal, provincial, and federal all have similar structures in place. So advocacy is not about finding one decision maker. It's about understanding the system as a broader thing, and knowing where your voice can have the most impact. So for many of you, that might not be at the federal to a federal politician. It might be someone in your local health system or provincial ministry, or even in your local municipality. So, one of the important things to understand in Canada is that we do not have one single healthcare system. We have a federated system, which means that responsibility is shared across different levels of the government. So, the federal government plays a role in things like setting national standards, funding, legislation. Provinces and territories are primarily responsible for delivering healthcare. And your municipalities and regional bodies are often playing a role in how services are implemented on the ground. So, what this means in practice is that the responsibility is often shared and sometimes can be overlapped. But if you've ever found yourself asking, like, who's actually responsible for this? And that's a completely normal experience. It's not always clear. And it's because policy development and implementation happens across multiple parts of the system. And this is one of the reasons why advocacy can often feel complicated, because you're not just navigating one organization, or you're not just navigating a system. It's multiple systems with multiple decision points, different roles, different priorities. I also just want to emphasize something before I move on. You don't need to know the exact right person immediately. A lot of advocacy and government relations work begins by asking questions and starting conversations and identifying who may be able to help or point you in the right directions. So there's not always one right door to knock on, and sometimes sometimes there's several people that you should be engaging in conversation. It's really about making a part of your work to figure out where to start and building those relationships over time. So another important piece is that these relationships that you develop are ongoing and but they're also constantly changing. So governments change, priorities shift, decision makers move in and out of roles. So advocacy is not a one-time activity. It's about building, maintaining, developing those relationships over time and continuing to engage as the system evolves. So when you think of it, advocacy feels really complex, and it's because it is a complex system. And we understand that that just getting to know this is the first step of really being an effective part of the advocacy system. So there's not one right door to knock on, as I said. There are several, and parts of this work is really figuring out where to start. So, just very quickly, this slide is about helping you understand where to focus your efforts when you're thinking about advocacy. So, as mentioned before, in Canada, the responsibility for healthcare is shared across different levels of government. So that means not every issue is solved by the same decision maker. So when we look at palliative care, we're looking at provinces being responsible for delivering funding care, including hospitals, home care, hospice funding, staffing. Federal government is responsible for setting national directions for funding transfers, national frameworks, and standards. And municipalities are tending to influence things like the local environment, so zoning for hospice residences or community supports. So when we're thinking about an issue, one of the most important questions that you can ask is who may have the authority to fix this, or who may be needed in this conversation. And because advocacy becomes much more effective when you're directing it at the right level of government, it's important to think about that. So, for example, if your issue is a lack of hospice beds, for example, or home care funding, that's likely a provincial issue. And if your issue is a lack of national consistency or data, that's probably a federal issue. And if your issue is trying to open or expand a hospice in your community, that's likely going to have a municipal component to it. So the challenge is not just identifying what your problem is, it's making sure that that you're asking the right government in the right way at the right level. So this is a really important concept to look at here when we're trying to understand advocacy. So we often assume that if we have really strong evidence, good ideas, clear solutions, that it's going to be enough to influence what's happening in policy. That's not really reality in how decisions are made. So government priorities really are shaped by a range of factors. So what's happening in the news cycle, what's impacting average voters, what's political pressures, including elections coming down the pipeline, what's the broader economic and social issues that are happening in the country. So right now, for example, there's major focuses on affordability, cost of living, economic stability, and at the same time, your priority and the priority of many people in this room is improving access to palliative care. So we know that too many Canadians are not receiving palliative care. People are not accessing it early enough in their illness. The system doesn't have the capacity to meet those needs yet. So there's often a gap between what you know matters and what the government is focused on. So this is really where advocacy comes in. Advocacy is not just about presenting your issue. It's about connecting your issue to what already matters to the government. So instead of saying palliative care is important, which we all know it is, it's about saying palliative care reduces pressures on hospitals. It helps address system capacity challenges. It improves efficiency and supports sustainability. It aligns with concerns about costs and resource use. So, a strong government relations strategy is really about learning how to position your issue so that it helps to solve the problems that your government is already trying to address. So, when we're talking about what government relations is, who you're engaging with, and why it exists, so that we've just sort of seen a bit of a picture of that, it's also important to talk about why your voice matters in all of that. So, one of the important ideas here is really that everything is influenced by policy, whether it's directly visible or not. We see this in our everyday life. So, policy shows up in things like the rules of how you move safely through your day, the services that are available in your community, the systems that support how you're living and working, how your family is living and working. And all the same is true in palliative care. Palliative care is really shaped by decisions about, what settings are receiving funding, whether hospice care exists in a community or doesn't, how services are structured, and who's able to access that care. So you may see this in your work when a patient can't access care in the setting that they'd prefer, or a hospice is operating at capacity, or services are not available in certain regions. So they're not clinical realities. They're really the result of policy decisions and where your voice matters, because the people making these decisions are not seeing what you're seeing in the everyday. So in many cases, they're really relying on your external voice to help them understand what's actually happening on the ground level. So advocacy is not just about raising important issues, it's about bringing forward your knowledge, your experience, your practical insights that can lead to better decision makings at the government level. So understanding how the government works helps you to connect those experiences to the system level decisions. And your experience is what helps bridge that gap between policy and practice. And in many ways, there's a big responsibility for us here. So if we're not at sharing our experiences, there's much less likely they're much less likely to be reflected in the decisions that are shaping our system. So over to you, Daniel.
Um, so up to this point, we've talked about what advocacy is, why it matters, and where it fits within the system. But now the question becomes, so what does this actually look like in practice? Advocacy is not a single meeting, it's not a single email. It's a process, and that process becomes much more effective when it is structured, intentional, and grounded in real priorities. We want to walk you through as a practical way to think about advocacy using established advocacy approaches and grounding them in the palliative care context and the blueprint for action. As we said before, government relations can feel complex, and unfortunately, that's because that's what it is. There's a lot of planning, strategy, and ongoing relationship building involved over time, but at its core, it can be broken down into 5 practical steps. Step 1 is defining the issue. That is about being clear on what the challenge is, what needs to change, and what the outcome you're working towards. It also means thinking about how your issue connects to the broader system priorities. In palliative care, we already have a strong starting point through the Blueprint for Action, which highlights gaps like access, workforce capacity, and public awareness, as Cheryl said. Step two is leveraging your voice. It's not about being the loudest voice, but it's about understanding what you bring to the conversation, whether it's clinical experience, community insight, research, lived experience. And importantly, advocacy is not just about raising concerns. It's about contributing knowledge and practical insights that can help shape better decisions and outcomes. Step three is building relationships. Advocacy is not transactional, it's relational. This step is, nope, hold on, sorry, back up. Step three is doing your research. This is one of the most important steps. It's important I don't skip over it. Effective advocacy is not just about what matters to you. It's about understanding what matters to government, what their current priorities are, where your issue aligns, and because that alignment, as Cheryl pointed out, is what makes advocacy effective. And step four is building relationships. Advocacy is not transactional, it is relational. This step is about identifying who the decision makers are, who influences them, and what matters to them, and beginning to build those relationships over time, ideally before you need something and not just when an issue arises. Step five is taking action. This can take many forms, such as meeting with decision makers, participating in consultations, contributing evidence, or helping to build broader awareness, and choosing the approach that best fits your audience and your capacity. And importantly, these steps are not always linear. Advocacy is an ongoing process. You can move back and forth between these steps as the environment changes, as priority shifts, and as new opportunities emerge. There is no single moment when advocacy is done. It's something you build over time. So, step one. Step one is identifying the public policy issue that matters. Any issue can feel important, especially in the work that all of you are doing. But in advocacy, not every issue is equally effective in bringing about change. Part of this step is being intentional about where you focus your efforts, because time and resources are always limited, and advocacy is most effective when it is targeted. A strong advocacy issue is one where the government has the ability to act, there's a clear gap and challenge, and there's a realistic opportunity for change. It is also important to think about whether the issue connects to the broader public benefit and system priorities, because that is where decision makers are ultimately responding to. In palliative care, we're fortunate in some ways because we have a somewhat clear picture about some of the system level challenges. Whether it's the CIHI Access to Palliative Care report in Canada or the Blueprint for Action, they both highlight that only about 58% of Canadians who could benefit from palliative care are able to access it. And many only receive care late in their illness and access varies significantly depending on geography and population. So we identify an issue, we are often connecting to what we see in practice to those broader system gaps. And that is important because effective advocacy is grounded in both experience and evidence. A helpful way to structure this is by breaking this down into three parts. First, the challenge. This is where you clearly describe the problem. You want to answer what is happening, who is impacted, and what are the consequences if nothing changes. The step is really about being clear and specific, using evidence where possible, because that's what strong advocacy is built on. For example, in a palliative care context, the challenge might be patients are unable to access palliative care early enough in their illness trajectory, which leads to increased hospital use and reduced quality of life. Secondly, the goal. This is about where you want decision makers to achieve. A strong goal focuses on outcomes, connects with system benefits, and aligns with broader priorities. Because advocacy is most effective when it fits in what the government is already trying to do or prioritize. For example, improving access to early community-based palliative care so that people can receive care in a setting that best meets their needs saves the system money by removing patients from especially acute care settings. Third, the recommendation. This is where advocacy becomes actionable. You are identifying what can the government actually do. From a policy perspective, that includes funding decisions, program development, or things like legislative, policy, and regulatory changes. And importantly, decision makers are looking for practical, realistic solutions that they can act on. For example, using this story we've laid out, investing in community-based palliative care programs and workforce capacity to improve access outside of hospital settings solves the problem we've raised. You may not always have a fully developed recommendation, but decision makers are much more likely to engage with you when you clearly define a problem, identify a goal, and suggest a path forward. Because advocacy is not just about raising issues, it's also about helping decision makers move toward these solutions. This step is really about moving the conversation from something is not working to here's what could be done differently. So From my perspective, I want to take a step back and share why these challenges in palliative care continue to persist, even when we know we have good ideas about what needs to be done. What this visual shows is what palliative care is what public policy researchers would call a wicked problem, because these issues are not isolated. They're part of a cycle, and that cycle reinforces itself over time. Let's walk through it. We often start with a lack of political will to act in palliative care. Even when there's awareness, palliative care is often competing with other priorities like acute care pressures, cost of living, and broader system demands. And this is something that we see across all areas of policy. Governments are constantly balancing competing priorities and limited resources, which means that not every issue receives the same level of attention. So even important issues can struggle to rise to the top of the agenda. At the same time, there's still a stigma and a lack of awareness among the public. Many people do not fully understand what palliative care is, associate it only with end of life, not aware of the benefits of early access. And we know from the blueprint that public awareness is a key gap that needs to be addressed. When awareness increases, something important happens. Demand for services increases. More people ask for palliative care, seek earlier access, and want to support themselves or their loved ones. This is a positive step because advocacy and awareness are meant to surface unmet needs and bring them into the system, but the system's not often ready to respond. We see that systems don't have capacity to meet demand, and this includes workforce limitations, limited community-based services, gaps in training and support, which again is reflected in the blueprint priority around skilled and supported care providers. But because of this, it becomes difficult to generate the evidence we need to inform policy solutions. Without consistent data, strong system-level evidence, and clear outcomes, it becomes harder to make the case for large-scale change. And we know that effective advocacy relies on evidence and clear information to support decision-making and influence policy. And that brings us back to where we started. Without strong evidence and sustained engagement, political will remains limited and the cycle continues. What this shows is that these challenges are not just system gaps, they are part of a reinforcing cycle. And I firmly believe that advocacy is one of the ways we can ultimately interrupt and break that cycle. But I also want to raise with you what I call the Incredibles principle. If everything is a priority, nothing is. We are not going to fix everything in the cycle all at once. It is not on any one person or any one organization to fix everything. When we are advocating, it's important to be strategic about what parts of these cycles we have the power to change and how we can break them.
So to bring this first step to life, I just want to walk through a concrete example. So this is an example of how you might take a broad issue and structure it in a way that's useful for advocacy. Because one of the key principles in advocacy is being able to clearly define the issue and communicate it in that structured way. So this is the type of structured thinking that's really going to help the decision makers quickly understand both the issues and the opportunity in what you're saying. So starting with the challenge. So the challenge here that we're going to use in our example is that there's no clear home for federal government within the federal government for palliative care research funding. So what this means in practice is that funding's inconsistent, research is fragmented, and it's becoming more difficult to build and scale best practices across the country. And this is important because strong advocacy starts with clearly identifying the issue and understanding its broader system impact. So this is a good example of a strong advocacy issue because it's clearly defined, it has system level implications, and it sits in an area where the government does have a role to play. So moving to the goal. So the goal builds on that challenge. So in this case, the goal is to receive consistent funding for palliative care research so that we can develop and scale best practices. So notice that the goal focuses on outcomes. It connects to improving care and it aligns with the broader priorities around quality and access because advocacy really is most effective when it connects to what the government is already trying to achieve. So this also connects directly to the blueprint priority around improving knowledge and strengthening the evidence base for care. So finally, as we move into our recommendation, this is where the issue becomes actionable. So the recommendation identifies what government can actually do. So in this example, this includes ensuring that palliative care research has a defined place within existing federal structures and creating accessible funding mechanisms that support that work. And this is important because decision makers are much more likely to engage when advocacy includes practical, realistic solutions that they can act on. So when you're looking at this example, what you're seeing is that the problem is clear, the goal is realistic, and that there's a practical path forward, and that's what makes an issue actionable from a policy perspective. So this is what step one looks like it really in practice. And it's not just about identifying something that's wrong, it's about structuring the issue in a way that connects the problem with the desired outcome and the potential solution. So once you have that clarity, it becomes a lot more easy to advocate.
Step two is about leveraging your voice. And this is where advocacy feels more personal because it's not just about the issue anymore, it's about what you bring to the conversation. One of the most important things I want to leave you with today is that government relations is a relationship. It is the relationship between you and decision makers is reciprocal. It is not a one-way interaction where you're just asking for something. Effective advocacy is built on an exchange. You bring something of value, and that is your expertise, and that's what makes decision makers more likely to engage. Think about it this way: it's your ask paired with your offer. Your ask is the issue that you want to address, but your offer is what makes you valuable to the conversation. What does that look like in practice? So, your expertise. If you have direct knowledge of how palliative care works in practice, that gives you credibility. Your information, that includes both data, but also what you're seeing day to day, which helps decision makers understand what is actually happening in the system. And your network. Many of you are clinicians. You're connected to other clinicians through organizations or communities. But even if you have neighbors, you have friends, you have other people in your network, and you can use that to demonstrate that this issue is broader than one perspective. And I want to pause on that one piece in particular. The stories you carry from patients, families, friends, your community, those are also forms of knowledge. They're not just experiences, they are insight into how the system is working or not working for people in real life and decision makers. And they need to rely on that input because they do not see those experiences directly. So when we talk about leveraging your voice, like we said before, it's not just about being the loudest voice, it's about being a useful voice. It is about contributing expertise, information, and perspective in a way that helps decision makers do their jobs more effectively. The more clearly you understand what you bring to a conversation, the more effective your advocacy will become. Step three is about doing your research. When we say research, it's not just understanding the issue. Many of you understand the issues in palliative care, frankly, better than I do. But this issue is about understanding the broader environment that's shaping the decision making, because effective advocacy is not just about having a strong issue. It's about understanding how decisions are made, who is involved, and where the opportunities are to influence that process. That includes things like what are the current government priorities, what pressures are the system facing, what opportunities are there for your issue to gain traction. Because advocacy is most effective when it aligns with what government has already focused on or trying to achieve. This is where it becomes important to understand that policy is shaped by a range of actors. Everyone can influence policy, but not everyone influences it equally. This diagram shows a collection of the actors that are impacted to achieve a policy goal. But they're not the only ones. Government often sets public policy agenda, and bureaucracy implements it implements the recommendations in order to achieve the goal. But they're not the only ones influencing decisions. You have opposition parties, media, general public, stakeholders like us. And together, this is sometimes referred to as a policy community where different actors contribute to how issues are understood and how decisions are made over time. All of these actors play a role in shaping what issues get attention, how they are understood, and what action is taken. But then importantly, you have to think about where you fit in this. As individuals working, in a hospice or hospital or in community, you're often seen as policy experts, whether you think so or not. That means you bring credible real-world insight and you understand how the system is functioning in practice, and you can help translate complex issues into something decision makers can understand. This is important because decision makers and the media often rely on expert voices and stakeholder input to better understand and inform decisions. So your role is not just to understand the issue, it's to understand that the issue fits in a broader system, who is influencing decisions, and where your voices can have the most impact. For example, when you think about a blueprint priority like improving access to palliative care research, your research might include the current funding models, workforce challenges, and how provinces are approaching care and where there are opportunities for alignment. Doing your research is not just about understanding the issue, but the environment in which the decisions are made. Then, building the relationships. So once you've clearly identified your issue, the next step is who you think about, who do you actually need to engage with to move this forward. You remember early in the presentation, we talked through the different levels of government and their roles. The slide builds directly on that because one of the most important parts of advocacy is connecting your issue to the right audience. Effective advocacy is not just about raising the issue, it's about directing the issue to the people who have the ability to act on it. Not every level of government is responsible for every issue, and building your contacts is understanding who is the decision-making authority, who influences those decisions, and who you should be building relationships with, because different actors with government and the broader system play different roles in how policy is developed. So depending on the issue you identify in step one, your list of contacts will look different. So if your issue is access to home-based care, your focus may be provincial. Research funding, your focus may be federal. A new hospice location, your focus may be municipal. This is why step 3 and 4 are closely connected. Your research helps you understand the system, and steps 4 helps you translate that into who you should be building relationships with. And like we discussed earlier, advocacy is relational. It is also proactive. The most effective advocacy happens when you're building relationships before a crisis or an urgent issue arises. So this step is not just about identifying names, it's about starting to build connections, understanding priorities, and positioning yourself as a credible and helpful voice, because decision makers are more likely to engage with people they see as informed, constructive, and solutions focused. The more clearly you can match your issue to the right level and the right decision maker, the more effective your advocacy will be. So once you've identified the level of government you need to engage with, the next step is to build your contact list, and this is where advocacy becomes more strategic, because it's not just about reaching one person, it's about understanding the range of people who influence decisions. And this is important because policy decisions are rarely made by one person. They are shaped by a network of actors, as we've talked about before. Sable outlines some of the key groups you might consider with engaging with in a palliative care context, starting with political leaders who set direction, establish priorities, and ultimately make decisions. But it's worth noting that also political staff are often key points of access, because they help manage issues and advise decision makers on priorities. Then you have senior bureaucrats. These are the people who develop policy, provide advice to government, and implement decisions. In many cases, they're deeply influential in shaping what is actually possible. They are also often the ones you engage with most directly, especially when it comes to detailed policy decisions. You also have opposition parties. Even though they are not in government, they can still raise issues, apply pressure, and influence public debate. They can also help elevate an issue to keep it visible. Parliamentary committees are another important group. They often study issues in depth, gather expert input, and produce reports that can influence policy direction. This is often where expert voices, including clinicians and researchers, can have a direct impact. And then there are stakeholders, which is where many of us sit. This includes health organizations, academic institutions, subject matter experts. These are the groups that help shape the conversation, provide evidence, and build momentum for change. And from a government perspective, stakeholders are a critical source of information and expertise that helps inform decision-making. And then finally, there's the general public. Public awareness and opinion can influence political priorities and create pressure for action, because governments are responsive not just to evidence, but also public concern and attention. The main takeaway here is that advocacy is not just about one person. It's about understanding the broader network of influence around an issue. So it's important to think about who's responsible for the issue you identified, who influences decisions, and who can help strengthen the message. Ultimately, these dynamics can take time, but even thinking this way will help make your advocacy a little bit more effective. Last step. Step 5 is taking action. Up to this point, we've talked about identifying the issue, understanding system, building relationships, but this all comes together where your advocacy becomes visible. At a high level, there's 3 main ways that advocacy action tends to happen. First, engaging decision makers. That could be requesting a meeting, participating in consultations, attending events where decision makers are present. This is where you can bring forward your issue, your experience, your recommendations. And this is an important step because direct engagement allows you to share information, provide your expertise, and contribute to how decisions are made. Secondly, there's building awareness and momentum. Advocacy is not just in those direct conversations. It's also through reports and submissions, media communications, broader public and professional dialogue. This helps raise awareness, shape how issues are understood, and build support over time. Because these issues are understood, how an issue is understood publicly often influences whether it becomes a priority for decision makers. And then last, strengthening your network. Advocacy is rarely done alone. This includes working with provincial associations, collaborating with national organizations, and such as CHPCA, and connecting with others who are working on similar issues, because coordinated voices tend to have more influence than individual ones. This is something we see consistently in advocacy. When organizations work together to align their message and work together, like the Palliative Care Coalition of Canada, it can strengthen credibility, increase impact. These actions don't happen in isolation, they have to happen together. You may share data with a partner who raises an issue publicly while you're engaging directly with decision makers. And this kind of coordinated approach is often what helps move issues forward. No single action will create change on its own. It is a combination of actions sustained over time that create momentum. Okay, So I'm going to work through an example of how we put things into practice around that. But I do want to say, like, reiterate, people say that governments are slow, but politics changes daily. A year and a half ago, Justin Trudeau was presiding over the demise of the Liberal Party of Canada. And now, Mark Carney has majority government in just 18 months. This is why it's important to actively build relationships so you can adjust the ebb and flow of these changes and tailor your tactics accordingly. There's many examples that you can raise in terms of specific activities within the House. Cheryl, if you want to move to the next slide. One of these tactics that CCS uses often is member statements. So we provided information to a member of Parliament, Lisa Hepner, to provide a member statement in the House of Commons in advance of the last round of federal, provincial, territorial health negotiations. In her speech, we don't have time to play it now, but in her speech, she highlights that CCS recommendation to make cancer care a priority in those negotiations, which we advocated. And then she personalized the issue by sharing the story of a volunteer from her community, and then provided statistics from a report that we shared with her in order to tell that story. Next slide. But there's also ways outside the House. So some examples, social media, I saw Ciencia on the list of folks attending. That's a great example of the waiting room revolution of how moving forward an issue. Social media does come with its own set of issues and disclaimers based on your institution, and that's a whole other kettle of fish. But other actions to advocate a public policy issue could be looking to influence elections or political party positions through platforms. So the PCCC tries to engage parties as they're writing their platforms to put palliative care in there somewhere. But I also, it's a little hobby horse for me, less than 1% of Canadians are ever get involved in a political party as a member. Look, there's a lot of ways. They have policy processes. There's lots of ways to influence what goes into a platform, and getting involved with the party can have a really big impact. But even if it's just attending like an MP's town hall or a holiday party, that's also an opportunity to raise your issues, to express your concerns. The next slide. So this is some of the ways we've done it: through advertising, through writing a report, through the lobby day, through a reception that we invited MPs to that Cheryl mentioned earlier as well. But I do want to take you through that specific example that we raised. If you want to move to the next slide, Cheryl. So we heard a lot from people over the years about financial distress that they experienced through cancer treatment. After many years of CCS advocacy, the federal government formally announced that the employment insurance sickness benefit would be extended from 15 to 26 weeks at our Center for Cancer Prevention and Survivorship in Vancouver in 2022. I want to particularly highlight this woman on the left in the gray hair, closest to the end of the slide, and tell you the story of how we got here. Next. So that woman on the left is the woman here with her local candidate at the time, Sean Fraser. Her name's Kathy McDonald. Her husband, David, was a carpenter in Nova Scotia who was diagnosed with esophageal cancer on his 50th birthday. He ended up passing away in 2013. In the final months of his life, he ended up going back to work and laying a floor for one of his clients so that his family could still afford to make their car payments. Something that Kathy vowed she would change for future families so they would have the financial support they need during their cancer journey. CCS has advocated for employment supports for people with cancer at the federal level in some capacity for decades. And we were able to get the expansion of the compassionate care benefits for caregivers in 2015. But people with cancer still only had 15 weeks. We also heard from people that even if they were eligible for EI support, there are still challenges in accessing EI and barriers for employment supports. So over the years, we've raised the concerns in a variety of ways, including our Ask of All parties in the 2019 federal election. Yeah, if you want to move to the next slide, please. Yeah. So our understanding came from what we'd heard from people with cancer and their families, but also their collaboration with other partners. We put together a partnership with MS Canada and others, a roundtable hosted by the Institute for Research on Public Policy in 2015, which laid out the gaps in sick leave policies, including EI. The key problems were identified that we have an EI program to help workers that can't work because it doesn't support people for long enough. While the federal government is responsible for some labor laws, mostly those working for the federal government, banking and transportation, all other industries are regulated at the provincial level. And each province has different rules for when you can take sick leave and for how long. And we also needed to advocate to each individual provincial government to align job protective leave policies to align with any changes to the EI program. Next slide, please. So some provinces, especially Quebec, have always been really receptive to that message. Quebec's the leader in this in many years. And like we ended up gathering one of the largest petitions ever in the history of Quebec to make that change possible there. That's not something we can necessarily replicate everywhere, but we wanted to make sure we knew it was possible to make this change. Next slide, please. But even as we had made that change in Quebec, it's not a guarantee that it came everywhere. So in 2015, this was the state of sick leave policy across the country. Most of these provinces were much further behind. Next slide. So to build traction on these issues, we convened key partners, including other health partners, Canadian Labour Congress, as well as leaders in the business community to build a consensus. We put together a landmark report which made a case to government on how improvements in EI policies specifically, and used a number of communications tactics to promote our findings. That was op-eds, news releases, bringing it up at every meeting, making it central to our election advocacy. And we worked in tandem with those partner groups like MS, Heart and Stroke, to do targeted outreach to regional caucuses, to push them champion this issue. And in particular, we got a lot of support from, thanks to people like Kathy in Atlantic Canada. And those MPs really helped us get the momentum we needed. It also happened in the context of COVID, where sick leave discussions were top of mind. Next slide. So in the end, in budget 2021, we were able to announce the government's intention to extend the EI sickness benefit. The budget ended up passing, and the policy change ended up being implemented by the end of the year, end of 2022. This was the first major EI reform, EI sickness benefit reform since 1970 when it was brought in, but we still need to do that work at the provincial level to align that change. Next slide. So we use the opportunity of the federal EI extension to reach out to provincial and territorial governments to align their policies. We knew it was a tough time to do that. There was, folks recall that, the war with Ukraine had just started, that caused a big rise of inflation, lots of other challenges along those lines. But we wanted to make sure this was aligning with the change, the financial support that people are getting the EI sickness benefit, so people would be able to return to their job after cancer treatment. Next slide. So we used a variety of tactics. Again, we recruited other storytellers beyond Kathy to also share their experience with us, but also in media and with decision makers to talk about why this was an urgent issue. We included all of our pre-budget submissions, our election priorities, all of our meetings with decision makers, and we worked collaboratively with labor ministers across the country to make the case for why they need to do this. We also filled in some of the gaps in economic research. We were able to demonstrate that the impact on businesses and government was not going to be significant in terms of economic impact. And in some cases, we'd be better off because it helped people, extensions in sick leave policies ended up actually helping people stay in the workforce longer and were more likely to, so employers didn't have to recruit or train a new employee along the way. If we had more time, I would share the specific example we shared. The Minister of Labor in Nova Scotia at the time where the policy was changed. She's a cancer survivor, and she talked about the impact that this would have on people like her and her family if this policy had been in place at the time of there. As Cheryl said in the chat, we're going to share these slides after. It's a great video. I encourage everyone to watch it along the way. You want to move on?
Sorry.
Yeah. So after that, this is where we stand. So we now have this job protected leave policy now in 9 provinces across the country. It's been introduced in New Brunswick, the last one, and we're expecting it to pass soon. We're continuing to advocate in the territories to get the work done there. And that doesn't mean we've solved every aspect of issues around financial toxicity, around a serious diagnosis. Like I said before, we can't solve every priority in every meeting. But I do want to share this example to show that it is possible to make meaningful progress on a nuanced and complicated advocacy priority across multiple levels of government working together in collaboration. So I do want to leave you some specific tips on where you can start. You don't need to be the size of an organization like CCS in order to make a difference. Joining organizations that do advocacy like CHPCA or Provincial Hospice Association, like HPCO, BC, HPCA, they do amazing work on that front. But there's also your professional association, whether it's, like CSPM, the nursing associations, things like that. You can also contact your local representative as just a person in the community or as an expert that you really have a voice to say. And next slide, please. And you can also do some outreach to the public. I know this part's scary. I'm an introvert. This isn't where I naturally feel comfortable. But you can make it, these are ways in which you can use this or work with other colleagues that may be more comfortable in this space to really mobilize why you are proud of the work that you do and why you're proud of the work that palliative care does. And that will go a long way to make the change that we need to see. Um, Again, we'll send these slides out afterwards, so I won't go through all of these. But there are some opportunities currently with the federal government. There's, strategies they're developing, longstanding issues, or big important discussions around the future of healthcare in Canada that are all happening in the coming months. So these are opportunities that you can take advantage of to start the conversation if you're looking for a place to start. And lastly, there are some tips and tricks that we've listed on the slide, but I just want to be clear. I do this as a job. There aren't a lot of meetings that I walk into where I come out with a check. That's because it's going to take time to build the change that we need to see, and we all need to work together in order to get.
Great. So as we wrap up, I just want to come back to where we started. So the blueprint gives us a shared understanding of the challenges and the gaps and the priorities for advancing palliative care in Canada. But what we focused on today is how those priorities can actually move forward because identifying priorities is only one part of the work. The change happens when those priorities are consistently brought forward, connected to the decision makers, and supported over time. So, through advocacy and government relations, we can bring forward what we're seeing in practice, connect it to the system level priorities, and contribute to meaningful change that's happening over time. And this is important because decision makers really rely on the input from people who are working within the system to understand what's actually happening and where the change is needed. So that does not require you to take on a completely new role. It starts with identifying the issues that you're seeing in your everyday positions. So sharing your experiences and your insights and engaging in the ways that make sense for you to engage in. So your experience is a great form of expertise that decision makers need because strong policy is shaped not just by data, but by the combination of evidence, expertise, lived experience. And when that expertise is connected to clear priorities, coordinated efforts, and strong relationships, it really becomes that powerful driver for change because coordinated and consistent voices are much more likely to influence decision makers and create momentum over time. And that is how we move forward with the blueprint for action. So thank you so much for everybody's time here today. And we are at the top of the hour, but if anybody did want a question or two, I'm sure we could probably stay and answer. Just going to stop sharing.
I do see one question in the chat, and I know I see some hands raised as well. The one question in the chat that I wanted to put to you, Cheryl, is are all of the provincial associations members of the Palliative Care Coalition?
So they are not. So the Palliative Care Coalition of Canada is made up of national associations, national organizations. So how the provincial palliative care associations fit into that is they are members of CHPCAs. So CHPCA and our priorities are listening to what's happening at the provincial level, and we're trying to feed that information back into the PCCC level so that the provincial voice and the provincial needs are represented in the Palliative Care Coalition of Canada, but they don't have a specific seat. So CHPCA represents those provincial associations, but it's through that voice to which they're coming to the PCCC.
And I will just add that many of those provincial associations also coordinate provincial level coalitions as well. So there's many opportunities, whether it's through the Quality Hospice Palliative Care Coalition in Ontario, the Hospice Care Alliance in BC. I know Manitoba has one, Quebec has some as well. There are other ways to get involved at the provincial level as well too.
They do, and they do really great advocacy work. A lot of the associations are really boots on the ground at the provincial level and in the national level as well to a certain extent. So the work that's happening there, I strongly encourage you to become members of your provincial association if you aren't already, because they are doing fantastic jobs.
Renee, I see has her hand up. Do you want to allowed to ask your question if you're still here, Renee? I think you should be able to speak now.
I think you're on mute. I'm not sure.
But I actually I appreciate what you presented, and there is things we could not understood. We could not understand before, but not we see. the problem and why a lot of people they need the palliative care, but actually they cannot get access to it because not only a lot of people among the population not informed, but we don't have enough resources, whatever it is,
Hmm.
financial, human resources, equipment, you know. So that's why this presentation is very good for us to understand where is the problem, how broader the problem is.
Thank you, Renee. Yeah, those
Yeah.
are definitely challenging issues that are happening across the country. So we appreciate your weighing in. It is challenging for sure. So we all have a role in playing and moving some of these issues forward. And what you're seeing is not unique to you. It's certainly a challenge for everybody.
Because me, I am nurse and I'm at the bedside of patient every day.
Hmm.
Sometimes you go and you don't find enough equipment to do what you're supposed to do. Sometimes I remember one time I went to somebody and the person didn't have any help and they were new in the country. I'm an immigrant, so he was new in the country and he didn't have any help. So me, I have to give him some reference that I know, but I was not sure that he could receive the help that he needs. But that's why the presentation is important. We can understand what's going on.
Well, thank you for that feedback.
Yes, and hopefully it inspires you to share some of the stories with more decision makers so that we can help mobilize people around solving these issues.
Exactly.
Yeah, great. So I see that we're 5 past the hour. We've already run 5 minutes over time, but I'm just going to say a big thank you to those who are still here. We will share the recording of the presentation and the slides. The video that Daniel had wanted to share with you, we will also include the link to that. I do encourage you to check it out. It's very moving. So thank you, Daniel, for being here. It's wonderful working with you, and we appreciate your partnership here at CHPCA. So hopefully we have lots of
Anytime.
opportunity to do this.
Yes, and anyone watching, please feel free to get in touch if we can help you in your advocacy in any way.
Absolutely. We'd be happy to. So have a great afternoon, everyone. Enjoy the rest of National Hospice Palliative Care Week, and together we're going to do good things. So take care.
Bye.
Thank you, Brian.